Hello, everybody. My name is Dr. Jim Douketis. I'm one of the internists here at McMaster University, and we're joined today by Dr. Aristeidis Katsanos, who is an assistant professor in the Department of Medicine and a stroke neurologist at the Hamilton Health Sciences, to provide a McMaster perspective on a recent article investigating the use of dual antiplatelet therapy in patients with ischemic stroke. Uh, Aris, welcome. And perhaps we can start by you giving us a bit of background as to the use of dual antiplatelet therapy in ischemic stroke. We're familiar with it in patients with an acute coronary syndrome, but perhaps you can provide a bit of a background about its use and development in patients with acute ischemic stroke.
Yeah, thank you so much, Jim, for the kind invitation. It's always a pleasure to discuss with you about the recent trials in stroke and advances in secondary stroke prevention. So I think it all started from cardiology. So we did see as neurologists the success of dual antiplatelet therapy in cardiology. So we wanted to do the same in stroke. So one of the first trials, big trials that they tried to do that was the MATS trial, including patients with ischemic stroke or TIA, but it used relatively, looking now with the very recent data that we have a very broad period for inclusion. It was patients within 3 months. So they were randomized to dual therapy or monotherapy. Unfortunately, it was a neutral trial. There was no significant reduction in the risk of MACE, and there was also increased risk of bleeding. So we're not very satisfied with that. So we weren't able to replicate the good results that we have seen in MI in the cardiology literature. But the first sparkle happened in 2013, coming again from China with the CHANCE trial. It was a big trial. So this time they focused more on their population. So first, they included patients with minor stroke. They had a scale. We have a scale as a stroke neurologist, which is called the National Institute of Health Stroke Scale, the NIHSS stroke scale. So they included patients with minor stroke, so they had score 3 or less in this scale. And more importantly, they should have their symptoms of a minor stroke or transient ischemic attack within 24 hours. So these patients were randomized to dual antiplatelet therapy with clopidogrel plus aspirin versus aspirin monotherapy. The dual was given for 21 days. So good results. We found a reduction in the risk of a stroke at 90 days, and there was no increase in the risk of bleeding. When the results were announced, there was a lot of enthusiasm, but also a lot of skepticism because the results were coming only from Chinese population. So there was some, I would say, some people were hesitant to implement those results into the clinical practice. In 2018, there was a similar trial done in the Western countries. So this is the POINT trial, again, using clopidogrel. Higher loading dose, 600 milligrams. Bigger duration of treatment was 90 days. Again, compared with aspirin, again, they included patients with minor ischemic stroke, NIHSS 3 or less, or TIA, and they have to be recruited within 12 hours. The primary endpoint was major adverse cardiovascular events. There was a reduction in the primary endpoint, and there was also a reduction in stroke. In that trial, we did see a high risk of major hemorrhages, but this trial was really important as it confirmed the results of the CHANCE trial and provided reassurance to us as stroke neurologists that dual antiplatelet treatment is in fact beneficial for people with minor ischemic stroke or TIA presenting within a time frame of 12 to 24, within 12 to 24 hours. So that's kind of like the background that we had up until recently, Jim.
Well, thank you. That's a very comprehensive summary. So there was a foundation for considering dual antiplatelet therapy. And the trial that we're talking about right now looked at an extended window to initiate dual antiplatelet therapy, and it involved over 6,000 patients. It was a randomized, double-blind, placebo-controlled trial, and it showed some benefits and a little bit of harm. So maybe you can elaborate on what your views of this study are in terms of the overall strengths and perhaps the weaknesses as well.
Yeah, for sure. So this is one of the studies you really like to see because it goes with your clinical practice. So I'll be honest, like people were calling me from the emergency, so they had a minor stroke or a TIA, and they were just outside of the window of the 24 hours. I always advise that there is a benefit even before 24 hours. And that was an assumption. We didn't have the evidence up until recently with this trial coming down from China. So in this trial, again, same rationale. So it was minor ischemic stroke. So the NIH was a little bit higher. So they allowed up to 5 points. So we were able to include a little bit more, a more broad population or TIA. The other thing is that they specified that the presumed mechanism of the stroke was atherosclerosis. So they took also some imaging evidence and carotid imaging into account to enroll those patients. But the most important is that they allowed for a pretty good time frame, which was 72 hours. And we know that most of the patients with a stroke, they're going to present in the time window. Most of them in Canada, they present within 24 hours. But in other parts of the world, there may be delayed presentation. So these 72 hours do make the difference indeed. So they found that there was a benefit in the primary endpoint, which was the reduction in the risk of stroke, with the downside, as you said, the increased risk of major bleeding, of course. This is really important because, of course, confirms the results of stance and point, but more importantly, gives us a little bit more flexibility as clinicians to use dual antiplatelet therapy in a little bit higher NIH score patients with more disabling deficits, and also to be a little bit more relaxed about the time window.
Okay, so good study and favorable results, both from in terms of net therapeutic benefit, about a 2% absolute risk reduction in ischemic events and only a 0.5% increase in bleeding events. Now, as you said, the population of study was in Chinese, Han Chinese. So do you think we need another study to replicate these results in a broader population in a similar way that it was done after the Chance trial, or do you think these results are robust enough that they can be generalizable to other populations? And I should point out, it seemed that the majority of patients, about 65% or so, were men. So how do you look at it just from a generalizability standpoint?
Yeah, that's an excellent question. As you said, there are limitations to the study. So, and more importantly, it was done in China. So we have to understand that we're talking about a different population. So we know that stroke patients in China, they have a higher prevalence of atherosclerotic disease and also intracranial atherosclerosis. Also, they are more frequently carriers of mutations of the CYP alleles that make clopidogrel less effective. Of course, the other thing is the standard of care, which may be different from other countries. It's a great question, how much evidence is enough? I think we should go back in time and just see the story between Chance and Point and ask ourselves, did we need the results of Point to influence our clinical practice? I think there are like people that would say yes, people that they would say no. But my take is that Inspires provides rationale for a practice that we have been already doing. So for me, as a clinician, I think that the evidence is robust and we can extrapolate, of course, with all these asterisks and limitations you mentioned into our patients.
Thank you. My last question is, let's say you get a call from the emergency department from a hospital about a patient, and they're outside of the window for thrombolysis, and maybe they're not a good candidate for thrombectomy. What would you recommend in terms of, or what do you do in terms of antiplatelet therapy? And assuming, as you mentioned, that most of them are, let's say, within 24 hours or 36 hours after the onset of symptoms, are there individuals that perhaps you would not recommend dual antiplatelet therapy. And when we're saying that, we're implying a loading dose of clopidogrel of at least 300 milligrams, and then the same in an aspirin in addition to that. So how would you handle a call like that from the emergency department?
Yeah, that's an excellent question, and you bring a very important point and something that we should highlight and mention. So these trials that we discussed about, they didn't include patients with thrombolysis and thrombectomy. So patients that receive acute reperfusion therapies, we have little evidence to support the use of dual antiplatelet. If a patient, as you said, is not eligible for reperfusion and they present, first I look at the time window. And now with Inspirus, I would feel okay up to 72 hours. Again, the sooner the better. Time is brain. And second, I do take a look at their neurological deficits. I want to make sure that the NIH is 5 or less. Second, I question myself about the mechanism. So I like if it is cardioembolic, I feel less compelled in dual, and if it is atherosclerotic, that provides more reassurance to me to suggest it. And the other thing that wasn't done in the trials, but I do it in my clinical practice, I'd like to take a look at the imaging, right? So I like to open up the CAT scan, make sure first of all that the infarct is not huge. Sometimes we have a discrepancy between the images that we see and how the patients are doing. And I'll give you also an example, like, posterior circulation strokes in the posterior cerebral artery. Patients, they can present with isolated hemianopsias, very mild deficits, and you can see a huge infarct. Sometimes you can see also hemorrhagic transformation in this infarct. So if I do see like a very big infarct, and especially if it has hemorrhagic transformation, I'm very reserved and I probably recommend aspirin. And of course, that comes also to the general picture. I assess also the bleeding risk of an individual, right? So if somebody is very fragile, if they had a recent bleed, or if there is something really, really concerning, I just weigh the expected benefits to the expected risks of the individual.
And one last question I just thought of. How long would you keep them on dual antiplatelet therapy if you initiate that treatment?
That's an excellent question. So trials, they use different time frames going from 21 to 90 days. So post hoc analysis suggests that the benefit is front loaded. So it seems that you get most of the benefit in the first couple of weeks, and then the benefit for the prevention of ischemia starts like washing away, and the benefit and the risk of bleeding starts creeping up. So what I do, I stick to the 21 days. But if I feel that there is a very high risk individual, I try to keep them at least a couple of weeks in the dual antiplatelet before I drop to monotherapy.
Dr. Katsanos, thank you so much for your insights. I think the last 15 or 20 years have witnessed tremendous advances in stroke care. This is one piece of that puzzle, and we wish you and other colleagues who are working in this area the best, because the advances have just been tremendous. So thank you for your continued work, and also thank you for contributing to today's discussion.
Thank you so much, Dr. Douketis. Thank you so much, Jim. It was a pleasure, and thanks again for inviting me to this discussion.
Thank you.